So hello and welcome. We have a very special disease to discuss. In the sense, it's a rare disease clinically, but it is a challenge for histopathologists. And we'll see why that is the case. And that is the reason why I picked up this case for today's webinar. So before we get into I'm more interested in talking about the histopathology and the challenges and the reporting formats of this disease. But let me give you an overview of the whole disease as such. So this is called as congenital megacolon. You know all that. This is an intraoperative specimen of the megacolon that you can see. So you should understand that Hirschsprung disease is a disease of the enteric nervous system. Now, this is kind of a neglected part of our entire nervous system. We talk of the CNS, we talk of the peripheral nervous system, we talk of the autonomic nervous system, but the entire gut has its own brain, it has its own way of thinking, it has its own actions, which is called as the enteric nervous system. Most of it, of course, is controlled by the parasympathetic nervous system. The sympathetic nervous system comes into play very few times. But this has a separate identity which we should all recognize. And that is what is defective in Hirschsprung disease. So this is a rare congenital developmental disorder. I think this is something which you will all know already. And it happens because of a migration defect. And what is this? The first passcode is 0. What does that mean? You can use the same passcode as the lymphoma panel. All right, moving on. This is a failure of the neural crest cells to migrate from the cranium to the caudal part during embryonic development. This is called as neurocrystopathy. Not a commonly used term, but something that you might want to remember if somebody talks about it. Now, this is the problem. The problem is that the innervation of the entire gut is incomplete, leaving a small ganglionic portion in the rectosigmoid area, even in normal people. But if the ganglionic or the hypoganglionic segment exceeds the normal limit, then we end up with this situation called as Hirschsprung disease. Now, this is the normal histology of the ganglion cells that you need to identify if you have to rule out Hirschsprung disease. So I am showing these images right up front. You can see these large ganglion cells with plenty of cytoplasm, almost plasmacytoid in appearance, a very peripheral large nucleus, prominent nucleolus. Very easy to also identify when present because they're always present in clusters. You can see that they're always present in bundles. So it's no big deal to identify it if they are present. But if they are not present or if there are hypoganglionic segments, then it does become one hell of a job to identify these ganglion cells. And where are you going to look for these ganglion cells? They're always going to be searched for in the rectosigmoid region, especially in the myenteric and the submucosal plexuses. Now, this is the general organization of the GI tract. Now, this is a cross section, so you can see the mucosa here, the submucosa, which contains the submucosal plexus, and then comes the muscular layers, the longitudinal. So between the longitudinal layer and the circular layer lies the myenteric plexus. So these red areas are the ganglion cells. They represent the schematic image of ganglion cells. These are in the submucous plexus. These are in the myenteric plexus, and we are going to focus on these. So if we draw a schematic of the GI tract. These are the layers, and I'm sure you're aware of these. So the topmost or the most interior part is the mucosa, which is made up of the lining epithelium, beneath which is the lamina propria. And in a minute, I'm going to show you the histology of this. The lamina propria, and then the demarcation between the mucosa and the submucosa by the muscular mucosa, a very thin layer of muscle coat. And in the submucosa, we are going to see the Meissner's plexus or the submucosal plexus. And then comes the muscle layers. They are made up of an inner circular muscle layer and an outer longitudinal muscle, between which lies the Orbach plexus or the myenteric plexus. Now, this histology or anatomy of the, and then of course you have the serosa, but this is what is important so far as we are concerned. This is where you are going to look for when you diagnose a Hirschsprung disease. So this is what I was telling you. This is the histology of a normal rectal biopsy. And as I said, this is the lining epithelium of the mucosa. And you have these areas between the glands, which represents the lamina propria. This is going to be the lumen. Then you have this thin layer of muscle, which is the muscularis mucosa. It's called mucosa because it is in proximity with the mucus layer, the mucosa. Beneath the mucosa is the submucosa. This is where you are going to find the which plexus. This is going to be the Meissner's plexus. Then sometimes you get lymphoid follicles, the inner circular layer, and you can see this distinction here between the circular and the longitudinal layers. And in between, you can already spot some nerve bundles. I don't know whether they will have ganglion cells, but they should if it's a normal case. But you can see these, the junction which has these nerve bundles. So it's important for you to know the normal histology, and only then will you be able to identify the abnormal histology. So this is again from the same case where you can see the Meissner plexus. This is the same set of ganglion cells. Very easy to identify if the child does not. It's usually a pediatric case. It's in the first year in infancy. And then you should also take a look at these nerve bundles. These are the second most important thing you have to. It's not just enough to look at the ganglion cells, but you also have to look at the nerve cells. We'll see how they are important as we go along. So what you should identify in the nerve cells or in nerve fibers is that you can see this as a very classic nerve fiber, where you don't see the perineurium, while as in a case of Hirschsprung disease, you will see a prominent layer of perineurium. And we'll see images, very high definition images of the perineurium in a case of Hirschsprung disease. Now this again, you can identify the same case, but again, take a look. The reason I'm repeating the same images is to really drive home a point that these ganglion cells are usually found in clusters if it is normal. They have a plasmacytoid appearance. They are very large cells. They have peripheral nuclei, prominent nucleoli, and abundant cytoplasm. Very easy to identify if they are present, if and when they're present. So this was the junction I was talking about. So this is the circular layer that you see on top, and this is the longitudinal layer, and this is the myenteric or back plexus. So this is another example of the Orbach plexus. At this magnification, unfortunately, we cannot say conclusively whether ganglion cells are present or not. We spoke right at the outset that the absence of ganglion cells is what clinches the diagnosis of Hirschsprung disease, which is why we call it as an aganglionic segment. Now, this is a higher view of the same thing. I'm sure you can identify a few ganglion cells here and there, but they're not many. So this could be, in all probability, a hypoganglionic segment. This does not look normal at all. You can also see these vacuolated areas. So very few ganglion, but there are ganglion cells. You can see the large cell nucleolus, but they're very few. So if we now, what I have done right now is I have described the normal histology because I'm setting up the stage for you to um, be able to make a diagnosis when we come to the pathology. So clinical features come next in line, and these are the classic symptoms in the baby. Abdominal distension, you can see this. There is also failure to pass meconium. This is usually the first symptom that the mother complains about. And there is bilious vomiting. This is a classical triad that is described in all books, including Bailey and Love. Now, there is a complete absence of the parasympathetic ganglion cells in both the nerve plexus, submucosal as well as mesenteric. I told you right away that this is the enteric nervous system, which is mostly controlled by the parasympathetic nervous system. Now, the radiology is very important because I keep emphasizing in most of my lectures that the role of a pathologist is no longer restricted to the microscope. We have to know everything about radiology. We have to know a lot about the clinical aspects. We have to know a lot about genetics and molecular diagnostics and all those kind of things. So we have an all-encompassing role in today's times. So we are like the 360 degrees knowledge people, knowledge bank for the other clinical branches. So as I said, it's a migration defect, and I won't repeat this. It's just to emphasize again. This impacts the distal most part of the GI tract, and it impacts the part which is further for the neural crest to travel. Now, the ability of the neural crest cells to travel from the cranial end to the caudal end almost stops at the level of the rectosigmoid junction. This happens even in the normal people. So it's usually a hypoganglionic segment even in many normal people here, but it doesn't affect our daily work schedule. But it does affect when it goes beyond a particular level. It falls below a particular level. So moving on to the pathology part, which is what the webinar is all about. This is the gross examination findings. This is a very classic proximally dilated segment, and this is the distal narrow segment. This is how it will look, and this is post-surgery, post-treatment of a patient. Now, here comes the important part, and although this is kind of partly pathology, partly surgery-related stuff, we should know what segments are affected. The aganglionic segment starts distally at the level of the internal anal sphincter. I will show you images of this, and extends proximally to variable lengths depending on how severe the Hirschsprung disease is. Now, in most of the affected children, the aganglionic segment, fortunately, is limited only to the rectosigmoid, which is then termed as a short segment Hirschsprung disease. In 3 to 10%, unfortunately, the entire colon is aganglionic. This is called total colonic ganglionosis. Now, there is also the other side, which is called as a very short segment Hirschsprung disease. It denotes an aganglionic distal rectal segment, which is very short. It's just 2 centimeters. But then again, it is ganglionic, which means it does not help with the peristalsis at all. Now, the problem is there is a high mortality. Mortality of 2 to 5% is still very high, despite all the advances in diagnostic, surgical, and medical care. So this is the normal anatomy of the anorectal region. We all know this. We know that this is the dentate line beneath which is squamous epithelium of this anus. And then from here comes the transition zone, and this becomes the columnar epithelium here. and this is the transition zone as they call it. The same thing can be seen here. This is stained with some trichrome, but you can see the ganglion cells here. You can see the ganglion cells. So this is belonging to the region above the anal canal. It's in the area of the rectum. So this is another way of looking at the same image, and this has been done so that we can correlate where we will get the ganglion cells and where we'll see the hypertrophy and all those kind of things. So this beige color thing with brick-like patterns, this is the squamous epithelium lining the anus. So you don't get any ganglion cells here in squamous epithelium. There are no nerves, no nerve twigs, just squamous epithelium. So this is a portion we are not going to worry about. Then comes the immediate adjoining part of the rectum. Now this has all the four layers that we had just discussed. Now physiologically, this is hypoganglionated. So this is even shorter in newborns, but it's less than 2 centimeters in newborns. But these are the ganglion cells. The pink cells are the ganglion cells, and these are the nerve fibers. Now, ganglion cells, if it is hypoganglionated, then they are absent or they are few. Nerves are absent, but they may be more prominent in some areas. Nerve twigs are present. We'll see how to identify these nerve twigs. They're not usually identifiable with routine stains. We'll have to use some special stains, and we'll see some very beautiful images of those. Mucosa is, this is the colorectal region now. Now, this is again not the ideal area for us to diagnose uh, a Hirschsprung disease, because you can get a false positive here. So we have to be very careful as to the exact location from which the biopsy needs to be taken. So this is the classic Hirschsprung segment, as they call. And this requires a lot of discussion between us, the pathologists, and the surgeons as to where you need to take this biopsy from. So as I said, the squamous or the most distal colorectal is not a good area. The Hirschsprung area, of course, we'll see how far it is. This is going to be more than 2 centimeters above the dentate line. The dentate line becomes the reference point. So from the dentate line, the biopsy needs to be taken somewhere between 2 and 3 centimeters. So that is the best zone and your best chance to identify or diagnose Hirschsprung disease. Remember this as a very, very important point for today's talk. Now, if it is Hirschsprung disease, then ganglion cells will be absent. If it is Hirschsprung disease, the nerve fibers will definitely be hypertrophied. See, compare the size of this nerve fiber versus this. It is very hyper. So we are looking at two features. One is the absence of ganglion cells. The second one is the hypertrophy of nerve cells. Both of them coexist. So don't just look for nerve cells. Don't just look for ganglion cells. If you start seeing hypertrophied nerves, then you are more confident that, and you will give a harder look at the ganglion cells. Nerve twigs are absent, while as they are present if it is a normal patient. Again, this is the colorectal region. The rest of all are colorectal regions. Now then comes what is called as the transition zone. The transition zone is again an area where ganglion cells may be present. Now this is the transition zone for the Hirschsprung segment. This has nothing to do with a normal person. So you may find a few ganglion cells. So this becomes a hypoganglionic area. So you can see a few ganglion cells, these pink cells. But again, what you see here are the hypertrophied nerves. So even in the transition zone, you will start seeing the hypertrophy. Then comes as you go more proximally, you will see a return back to the normal areas where the nerves are normal, the ganglions are normal. So again, these areas are not the best area. This is definitely not going to give you a diagnosis. So this will give you a false negative here. If you take a biopsy here, you will report it as normal. You will not say that the patient has Hirschsprung disease. Here you do a biopsy in a hypoganglionic segment. You will give a report which is ambiguous. You will not be sure whether this is Hirschsprung or not. So the best area is going to be between 2 to 3 centimeters above the dentate line. Now, this could be one of the most important slides if you want to know exactly where to take the biopsy. So these are the diagnostic procedures a patient must undergo. Patients who have with a high index of suspicion should undergo a methodical diagnostic evaluation. Now, there are two screening tests that are available for the clinician. This is not for us, but for the clinician. They can do a contrast enema, which we saw in the earlier radiology. And the second one, which is supposed to be more accurate, but very, very cumbersome and very painful, which is anorectal manometry, where you actually measure the pressure inside the bowel. So the patients typically less than 1 year of age who have findings which are suspicious of Hirschsprung disease are recommended to undergo what is called as a rectal suction biopsy. This is the most common type of biopsy that is performed. However, if the patients are more than 1 year, or if the findings are equivocal, which means ambiguous, then you do a full thickness biopsy. I'll show you some images which show now this will cover only a rectal suction biopsy, by the way. Will take a biopsy only from the mucosa and the submucosa. It will not include the mesenteric plexus. Well, as a full thickness biopsy will include the mesenteric plexus as well. As I said, in patients older than 1 year of age, a full thickness biopsy is recommended over a rectal suction biopsy. Another important thing to remember for you. So this is a classic rectal suction biopsy device, which has a barrel and a syringe where you actually apply suction, and this is pushed into the rectum like this. At the edge, you have a cutting blade and it will pull. You can see that this is the mucosa. The yellow part is the mucosa. The pink part is the submucosa, but it is not taking the muscle coats. It's not taking the longitudinal or the circular muscles. So what you get effectively with the rectal suction biopsy is just the mucosa and the submucosa. However, in children less than 1 year of age, this is the recommended method. So you have a blade here inside, which can actually cut. This is the blade which moves and it will chop off this part. And the suction is applied and the biopsy will come into this syringe, which can then be harvested. So this is a protocol. Pre-operative rectal suction biopsies are done to establish a diagnosis. Typically, the children are less than 1 year. Now, this is important for us, the pathologists. The biopsies must be more than 3 millimeters in diameter, and it should contain at least 1/3 of the thickness of the submucosa. Now, if you don't get this, it will be very, very difficult for you to come to a conclusive diagnosis of Hirschsprung disease. So these are the prerequisites that need to be discussed with the surgeon. If the surgeon is unaware, or if he's a young surgeon or whatever. And typically the location, as I said earlier, should be more than 2 centimeters above the dentate line to avoid the physiologic area of hypoganglionic cells. And when the specimen comes to the lab, we have to do multiple serial sections. I tell you, it's very difficult to make a diagnosis with one section. It's impossible to make a diagnosis unless you are kind of overconfident or unless you are ignorant. So if there are no ganglion cells, you take as many as 75 sections. You just go on doing it until you exhaust the entire block. You have to continue taking sections. And then there is this immunohistochemistry with calretinine, which is a very fabulous technique to aid in your diagnosis. It's an ancillary method, very, very, very useful. So in most cases, if you follow the protocols, which means 2 centimeter above the dentate line, thickness, the width of the biopsy being more than 3 centimeters, and it is at least 1/3 of that includes the submucosa. Then that is called as an adequate biopsy. Now, this is a full thickness biopsy, by the way. So we also have the muscle coat. So I'm not talking of this. I'm talking of the rectal suction biopsy, which will exclude this area. So an adequate biopsy along with absent ganglion cells. I think you can now appreciate that there are no ganglion cells here. You can also appreciate how thick this bundle is. So there is nerve hypertrophy, absent ganglion cells. We'll see more and more images and very high quality images. And of course, you need a very experienced pathologist and you will land in a correct diagnosis. So in most cases, this is sufficient if you do it properly. And as I said, you have to take many, many serial sections. So a definitive biopsy ultimately requires an adequate rectal biopsy. All the radiologic findings, all the manometric findings, all the clinical findings are still not enough to diagnose Hirschsprung conclusively. So a definitive, the gold standard is always a rectal biopsy from the correct spot at the correct juncture. Now, as I said, at least 1/3 of the thickness should be submucosa, especially in the rectal suction biopsy. So this pale pink that you see is the submucosa. So of the entire thickness, at least 1/3 should be submucous. Only then you will call it as an adequate biopsy. And if you have that, you can actually only with HND ensure a 90% diagnostic accuracy, which is very, very good. But look at the flip side, you need at least 60 sections. It's an expensive project. Taking 60 sections from one biopsy can be expensive and also laborious. So this is a classic suction biopsy which goes from the epithelium lamina propria right up to the. So these are the ganglion cells that you find in the submucosa. So the biopsy goes up to this point, this brown area. But see how the myenteric plexus is not included in the biopsy. Only this part is biopsy. This is a classic suction rectal biopsy. As a pathologist, you should know this. While as this is a full thickness biopsy, the only definition of a full thickness biopsy is the presence of both plexuses. So far as we are concerned, we need both of them. And if it is a suction rectal biopsy, then we need at least 1/3 of this entire thing to be made up of submucosa. So just to drive home the point even more conclusively and mathematically, I have drawn an actual scale here. So this is the dentate line. This is the dentate line you can see even inside. So from there, you have to go, you should not take a biopsy up to 2 centimeters. So 2 to 3 centimeters above the dentate line is the best zone. So this bandwidth that you see here is the best area to take a biopsy. It's a very small segment. It's just a 1 centimeter segment. So if you go too high, I already showed you what happens. You will find the normal quantum of ganglionic cells. So you will give a false negative. You will say there is no Hirschsprung disease because you may actually hit a lot of ganglion cells here. And the opposite will happen here. You will give a false positive because this is already a hypoganglionic segment physiologically. So you will say that this is a Hirschsprung disease. It's a false positive. So this is the best zone. Please remember this because many times we have had examples where the surgeons talk to us and ask us, where should we take the biopsy from. Now, although this is the best site, it is advisable to take multiple biopsies from every level, but this should be marked separately. But multi-level biopsies, very important. But as a pathologist, you cannot look at this and give a false positive and this as a false negative. That's what you should know. It's not the headache of the surgeon, but it's our headache to know where to report the biopsy from. So more instructions for the surgeon. So we have to advise the surgeon to procure biopsy from multiple levels and also send them in separate containers. Each level has to be labeled separately and sent in separate. I have seen this multiple times. They tend to send all of them in one bottle, in one container, which is so very frustrating. And at the end, we are completely unable to make a proper diagnosis, especially if it is lacking the ganglionic cells. Now you can also see um, what is this? We cannot ensure the correct biopsy size. That's correct. Yeah, unless the surgeon tells us. So this is the typical rectal suction biopsy gun that we were talking about. And we should also recommend, I mean, I think you are following these procedures already for small biopsies and endoscopic biopsies, where you have a foam pad inserted in a cassette, which will absorb the blood clots and uh, no. 2 to 3 centimeters, you don't take 60 sections. 2 to 3 centimeters, you take one or two biopsies. But when it comes to the lab, this biopsy that comes, you have to take sections. You have to take multiple sections like this from the block, 60 sections. Or if not 60 sections, at least you have to take, you have to exhaust the block, right? And if the biopsy thickness is less, you should actually tell the surgeon to take more sections from that bandwidth of 2 to 3 centimeters. You have to hit the diagnosis this way or that way. So we have to do whatever it takes to get to the correct diagnosis. So use a foam pad like this, and that will absorb the blood clots and stuff. And this is what you talk to the surgeon about. You can see that it's a good habit to follow for small biopsies. And then comes the orientation part. It's up to you. For every biopsy, you should know that the submucosa will be facing. So if you decide that this is going to be the submucosa part and this is going to be the mucosa part, for all the biopsies, the multi-level biopsies, each one should have the same pattern. You should not have varying orientations for your biopsies. But yeah, it's a lot of stuff. You'll, as we go along, you'll see even more than 60 biopsies that are performed by other people. So this was what I was saying. So the optimum size of the biopsy has to be 3 millimeters in size. So this is not difficult because that is the bite size of rectal suction biopsy thing. So this is how it looks. I mean, it's pretty scary if you look at it. As a routine protocol, cut lots and lots of sections because the yield of ganglion cells is very low in Hirschsprung disease. So this is now look at the results. These are 5 slides. These are from 2 biopsies taken from that bandwidth of 2 to 3 centimeters, just 2 biopsies. And 116, if you count, you will see 116. So these are the 2 biopsies. So you will see 116 levels in these 5 slides. And what is the yield of ganglion cells? From all the 116 levels, you can just spot 2 ganglion cells. And unless you hit that sweet spot, you are never going to make a proper diagnosis. So it's a lot of hard work. It's a hell of a job to diagnose Hirschsprung disease if the ganglion cells are less. Now, that is precisely the challenge with Hirschsprung disease. You are looking at negative findings. You are trying to, it's not like finding a keratin pearl in a squamous cell carcinoma, which is a positive finding. You see a malignant cells, you see abnormal mitosis, it's a positive finding. Here you are looking for absence of findings. You are looking for absence of a particular cell. Now, if the cells are not present, you have to hunt them down. So the process of hunting down something, especially when the numbers are dwindling, is one hell of a job. And that is precisely the problem with Hirschsprung, and that is also precisely why we need a really experienced pathologist with tremendous patience to be able to examine 116, 120 levels. It depends on the pathologist and also on the surgeon and the high index of suspicion that you have. If you are really sure that this is a case of Hirschsprung disease, you should move heaven and earth and ensure that absolutely no ganglion cells are found. So I cannot emphasize enough. Don't even ask me whether this is the optimum level. It could be more, it could be less. You might spot ganglion cells, say, after, say, 20 slides. Or you might not spot anything after, say, 150 slides. So nothing can be said, and there is no real gold standard that you have to do something um, in a particular way. Yes, and you have to train the technician. Yes, Dr. Sachin Kale is asking. The biopsies have to be labeled. I mean, irrespective of what biopsy you are looking at, it has to be labeled very correctly, because we are talking of multi-level biopsies, and that Hirschsprung bandwidth that we are talking about, that in particular can be labeled with a different ink. It can be color coded in whatever way you want. Um, so if you see two ganglion cells, can we call it as a Hirschsprung disease is one of the questions. No, you cannot call it Hirschsprung disease, but you can at least call it as a hypoganglionic segment. You have to explain. See, this is more of a thing where you discuss. I mean, the patient, if you recall the first slide that I showed you on the PowerPoint, we were looking at a very bloated piece of colon, and that immediately got us thinking, the clinician, if he does a radiologic exam of barium enema and finds a bloated area in the colorectosigmoid area, he will say that this is a Hirschsprung disease. Now, the onus is on us to uh, now, the other reason why finding even two cells is important uh, is that even if you conclude that this is indeed a Hirschsprung disease, where you have complete absence of ganglion cells, or because of hypoganglionic segments, you still have to perform a surgery and join the two stumps, and you should know where you should join. I'll come to that part also. Our job is not done only by making a diagnosis. The reason why we have to hunt down these two ganglion cells, even if there are just two ganglion cells, is because we have to further advise the surgeon as to how to anastomose two segments between the hypoganglionic segments. We'll see how that is done again. Very interesting. But let's look at the hypertrophied nerve fibers. So you can see these thickened nerve fibers, very thickened, very big. Studies have been conducted, but you can see these gray striped areas. These are the Hirschsprung segments, and the black ones are much smaller in diameter. You can see that 10 micrometers through 60 micrometers. If you take sections at 60 micrometers, you don't even see normal segments. They will end at 20. They don't cross the size of 20 micrometers in width. Okay, the width, not the length. So the width cannot go more than this in most of the cases. Well, let's look at how it is skyrocketing. This big skyscraper is a part of the Hirschsprung segment. Very thickened. That is one aspect. The second thing is to look at the prominent perineurium. You can see the perineural nuclei. You can actually see the perineurium. You can see this slightly darker pink perineurium here with its very slender nuclei. So again, you need the eyes of a hawk to be able to make this diagnosis. Experience really matters. You have to work really very hard to be able to come to this diagnosis. So, which is why I have put up such high definition images so that you can. But again, you don't see any ganglion cells anywhere in this image. This is actually a case of diagnosed Hirschsprung disease. Now, this is what I said when we say about hypoganglionic, very few. If you recall the earlier image where we saw a huge cluster of like at least 10 cells, here you can see only one or two cells here and there. So this is a classic hypoganglionic or back plexus or the myenteric plexus. Now this is again for reference or for orientation. This is the circular layer and this is the longitudinal layer. But this is a hypoganglionic segment. Now, if you have to perform surgery and join two segments, you cannot join a hypoganglionic segment with a normal segment. You have to join a normal with a normal segment. This is very, very important. I mean, suppose you have done all your searches, you have used up your 116 or 120 or 200 slides or whatever your strength permits you, and you are yet not able to say conclusively that this is a case of Hirschsprung disease, then we have some ancillary tests that can help us. There are two which are very important, out of which one of them is my favorite. I'll tell you why. This is the acetylcholine esterase stain. Now, the brown areas are all, this is a case of Hirschsprung disease because you don't see any ganglion cells. These are all thickened bundles. So it is positive if the patient is having Hirschsprung disease. Okay, so this is again acetylcholine esterase. Um, okay, so this is a typical ganglionic rectal biopsy from an infant who does not have Hirschsprung disease because this is where you can see the ganglion cells. And I think I made a mistake here by saying that this is Hirschsprung disease. This is not Hirschsprung disease because it stains ganglion cells. And you can also see the thin nerves here in the muscularis mucosa. What am I saying here? Yeah. So in the typical aganglionic rectal biopsy, ACHE histochemistry shows plenty of thickened nerve fibers. Now the problem with acetylcholine esterase is, I'll show you the next stain and then we'll come back to this. It's because one of the big problems with using this stain is you can do it only on frozen sections. Frozen sections are not usually available very easily, and it requires special methodology and special efforts. Now, as it is, diagnosing Hirschsprung is not easy. So if you don't have a cryostat, or if that is a problem, then it makes life all the more miserable for a pathologist. But here is a case where you can identify these nerve bundles of Hirschsprung. So again, you can see positive ACHE here in the myenteric plexus. Now this is another stain, which as I said is my favorite. It's called calretinin. Now this is positive only if ganglion cells are present. So again, I was telling you that diagnosing a Hirschsprung is about diagnosing a negative finding, which means the absence of ganglion cells. So if there is some ancillary method which gives us a positive signal, and calretinin is positive only if ganglion cells are present, So these thin strands that you see are calretinine positive. So now I can say that whether I look at 300 slides or whatever, I will know that ganglion cells are present. So I am almost confirming that Hirschsprung is not there if calretinine is positive. So that's quite heartening. So if you remember one of the earlier slides, I said that HND is good enough if you have a good biopsy and if you have a competent pathologist. But if at all it comes down to using ancillary methods, use calretinine rather than ACH, because ACH is again a negative kind of thing. And then you have the other issue of using only frozen sections. So you can see these beautiful twigs, nerve twigs that are seen. So if you see these, then this is a very reliable ancillary stain to rule out Hirschsprung disease. So use calretinine, and if you see these twigs, this filigree of brown branches, this is in the submucosal lamina propria area. So then you know that you will, if you look at the biopsy diligently or the multiple biopsies diligently, you will be able to find ganglion cells somewhere or the other. So this is, according to me, a better way. So as I said, it's a good ancillary test. In Hirschsprung disease, there is no staining with calretinine, while as if you see these brown twigs, then it excludes Hirschsprung disease, at least in that area. So this is what I would recommend. Now for the ancillary tests, again, this is again going to take up a lot from your technician, your histotechnician. It's going to take a lot of time from you as well. You have to invest time. So you have these regular HND sections here, and then this is calretinine, and this is the acetylcholinesterase. So you can see that these are the ganglionic segments. These are the ganglionic controls. These two are the controls. You need controls. Otherwise, you will never be able to identify whether this calretinine is actually positive or negative unless you actually see those twigs in the control ganglionic segment. You need to see the twigs here. And if you see them here as well in the patient, then you're on good ground. You can say the patient does not have Hirschsprung disease, whether you see the ganglionic cells or not. You can still tell the surgeon that we'll have to take more sections, we'll have to do something extra. This does not need frozen section. Calretinine can be done on regular paraffin blocks. That is also a very big advantage versus acetylcholinesterase always requires frozen section. Now the treatment. Now treatment part, do you think our role is over by just making a super diagnosis? We have seen, you cannot go and brag that I have seen 200 slides and made a diagnosis. That's not enough. Your role is not over. We need to remove the ganglionic segment. So there is a healthy part, there is a diseased part. So the diseased part is chopped off, and then the anastomosis needs to be done between the, so this is the area which needs to, so this white area, if you can appreciate, the other ones are gray. So these are the zones that need to be examined intraoperatively. So again, frozen sections will be sent to you during surgery, and you have to quickly be able to look at them and tell them whether they have adequate ganglion cells in this area. Otherwise, there's no point in anastomosing again to ganglionic or hypoganglionic segments. So it's very important that you participate in the surgical process of repairing this segment as well. So intraoperative consultation will include a surgical team. The frozen sections of the proximal surgical stump in particular will be sent to you. And again, the role of an experienced pathologist in telling them that, okay, this is a good anastomotic point that you can. So you take a 3-step approach. Now, the frozen sections that are sent to you from the proximal stump are called as leveling biopsies. So that is the level which needs to be anastomosed. So the leveling biopsies to find ganglion cells, identify a site oral which is proximal to the ganglionic segment, and they will send you small bits again. The surgeon should perform resection at least 5 centimeters proximal to the leveling biopsy with ganglion cells. If we report that the ganglionic segment is between 2 to 3 centimeters, he needs to go at least 5 centimeters above that and then join. Now, the frozen section of the proximal margin will be sent to you to exclude features of the transition zone. Transition zone, if you recall, is that hypoganglionic area. And this process will go on. It's a very long surgery, actually, not very long in terms of stitching together two segments, but for us, we have to be there. For us, it will take hours because one after the other, the frozen sections might keep coming in. I don't know how many of you actually get hold of these cases. So this is a leveling biopsy frozen section. If you can read this part. And what do you see here? So we can see ganglion cells at the interface. So these are the circular muscle fibers, these are the longitudinal. So this is a good point for us to say that, okay, this is a good point. You can now anastomose. You can use this segment for anastomosis. Now, suppose this was not found, then you will ask him to take a biopsy even proximal, higher up. So excluding the transition zone, you can imagine that this is a schematic of the thing. So 5 centimeters proximal to this area. So this is the frozen section that is sent to you, and you are seeing these ganglion cells. You still have to play on the safer side, go 5 centimeters above this and join this segment with the proximal end, with the area above this. You don't join this area immediately because you don't know if this is still hypoganglionic for maybe another centimeter or whatever. So this is what happens intraoperatively. See, one small thin layer is, now this is the intestine, okay, this is the colon, the rectosigmoid area. This much is kind of sliced off. It is sent to, this is our frozen section folder. And we take multi-section levels again, and we have to exclude the features of transition zone. So partial circumferential ganglionosis, myenteric hypoganglionosis, and submucosal nerve hypertrophy. These are the 3 features you have to rule out. So at the circumference, you should be able to see ganglion cells. In the myenteric plexus, you should be able to see adequate ganglion cells. And you should not be able to see hypertrophy of the nerve. Then you can give a green signal. Otherwise, you have to continue asking him to go proximally. If you see the transition zone, say at this level, then you say that, okay, go higher up and take another biopsy, say maybe 1 or 2 centimeters. And he'll go back and send you another frozen section from here. Then you have to examine and tell him that, okay, this area is okay. If you see adequate number of ganglion cells and the absence of nerve hypertrophy. Otherwise, you keep going for a few more centimeters. Ultimately, you will hit gold and you will be able to give him the correct transition zone. So this is called as a leveling biopsy. So this is the extent to which a pathologist needs to be involved. So a sample biopsy report, so that if at all you do come across such a case, this is from a regular rectal biopsy, a suction biopsy. You can say that the findings are diagnostic of Hirschsprung disease because there are no identifiable ganglion cells. These are the bare minimum things that you need to mention, which is what I'm trying to do here. You should mention submucosal nerve hypertrophy. And as I said, calretinine. Absent calretinine. If it is positive, if you have a calretinine positive, then this is not Hirschsprung disease. So these 3 features are mandatory for a histopathologist. If it's a pull-through resection, which means you have a complete treatment, this is of a Hirschsprung disease, then you should be able to identify a ganglionosis, and there is no neuromuscular pathology at the proximal. So this is what the frozen section part that I was talking about. Then after resection, you can create a synoptic report. Nowadays, synoptic reporting is very, very important. There is a very, very, very good online resource that can be used. This is the resource. It's called Hematogones. Now, I'm sure you are aware of this website. It's a very good website. What it does is so that you don't miss out anything. It has this kind of a drop down menu where you can go on filling these boxes. The type of pull-through procedure, the surgical technique, there's a process called a SOV technique. Then what is the total length of the resected distal ganglionic segment? The total length of the proximal ganglionic, if it is applicable. This is about the frozen sections in particular. The anatomic location of the transition zone. Then these are the various histologic features. There are no neuropathy. I hope you can actually read them because they're very interesting findings. No neuropathologic feature of transition zone. Partial circumferential ganglionosis. Myenteric hypoganglion. You can pick whatever is correct in your case. Submucosal nerve hypertrophy, which is subjective. Even that is one of the accepted ways of creating a synoptic report. If you have a way to measure it, if you have a micrometer attached to your microscope, you can do that. And if there is frank hypertrophy, then you should maintain that. And then if you have to add notes, you can do that. So this is a very good site. You can utilize it whenever you come across that. My only request to all of you is if you come across a case of Hirschsprung disease, a diagnosed case, or if it turns out to be not a case of Hirschsprung disease, then I would still want you to go and do a synoptic reporting. Don't just give a descriptive report the way you give don't give a one-line report if there's no features of Hirschsprung disease seen. Go to this website, it's all ready-made for you. Create a proper synoptic report, because all your reports will be read by the gastroenterologist, surgical gastroenterologist, and your report might go to so many other places. So that will create a very proper, good impression about you. The last slide is that of Chagas disease, which can also cause something like Hirschsprung disease. We all know this. So this is a case where you can see the trypanosoma. This affects adults. So it's not a case of infants. I just wanted to add this slide so that this whole topic comes to a full circle. So thanks for watching and thanks for attending. If you have questions, I'll take them after I